Welcome, Heartland Health Center's Facebook family. I am so excited to have you guys here joining us for this awesome conversation today. Today, we are going to be talking about opioid addiction, dispelling myths and saving lives. And I am so happy to be here and to be here with the MAT team. Who am I, you ask? I am Gina Smith. I am the Community Outreach Coordinator here at Heartland Health Center. And a part of my role is to work with this amazing team, which is the MAT program. And my job is to increase the awareness and the patient access to this program. And so also, some of you guys may not know what MAT stands for. It stands for Medication Assisted Treatment. And basically, it is a patient-focused substance use program for opioid use disorder. So today, I have some of the key people who are a part of our MAT program in Heartland, and I am excited. I would love to introduce them, but they would do it so much better. So, Emily, tell us who you are, girl.
Hi, my name is Emily Berwald. I'm a family practice nurse practitioner. In addition to primary care, I specialize in addiction medicine, treating primarily opioid use disorder with, as Gina said, medication-assisted treatment, also known as MOUD now, but I can get into that later. And the primary medications we use are buprenorphine, often known as Suboxone, and naltrexone, also known as Vivitrol.
Thank you, Emily.
All right, I am Rihanna Cheek. I am a medical assistant as well as the MAT program coordinator. So I do all of our scheduling, calling in prescriptions, things like that.
And lastly, my Michelle.
Hi, I'm Michele Nucup. I am a licensed clinical professional counselor and a certified alcohol drug counselor. I work as one of our behavioral health consultants with Heartland Health Center, and then I specialize in behavioral health consultant as part of the MAT program. Came on in 2016 as the MAT program coordinator, and then moved on to behavioral health consultant, and then now we have Rihanna as the coordinator. And so we've all been enjoying working together and providing the care for patients.
So as y'all can hear, we have some amazing panelists today. And so we're just going to go ahead and jump right on into the questions. So what is opioid use disorder, also known as OUD?
So I think, yeah, I can start off with that. Opioid use disorder, or any use disorder, is kind of characterized, not to get so diagnostic statistical manual about it. It's characterized by an unhealthy relationship or a problematic relationship with a substance. So today we're focusing on specifically opioids. We'll get into a little bit about examples of opioids, but for example, heroin, anytime somebody finds themselves using too much, it becomes something every day. They build a tolerance to it. They might have withdrawals. It's really difficult for people to stop. It's really difficult for people to stop because of the physical withdrawals from the physical dependence aspect. It becomes really difficult because of the triggers and the cravings of it. But anytime somebody is experiencing some impact in their life, a negative impact on their relationship with their self, their ability to go to school or go to work or maintain relationships. So there might be an impact on their family members, their loved ones, or significant others, their children, or there's an impact, on their job performance. It's really difficult for them to maintain kind of the day-to-day work or just day-to-day activities in general. Maybe this leads to some legal issues, DUI or other legal issues. So, it's kind of characterized by just the level of the impact and the level of how much of a problem has this become, and how is it affecting the person's life is kind of how we start to really think of it on a spectrum as a use disorder. Yeah.
Thank you for that thorough answer. I loved it. So what exactly is an opioid?
So not to again get too technical, but an opioid is any chemical compound that biologically stimulates our opioid receptor. So there's tons of different ones and different levels of, different intensities of strength. Like we know fentanyl to be very, very strong. Fentanyl is used traditionally, or legally, and anesthesia to put people to sleep, also used in patches to manage extreme pain, and OxyContin, Norco. These are all prescription opioids that people are pretty familiar with, but the goal and the reason opioids were designed were to treat pain, very severe pain, and to produce anesthetic effects, like we see in fentanyl. But it's also been seen in, illicit substance use and in street use, and that's when we see different pill forms that might be from, some market elsewhere, but we don't always know what's in those pills. But often we see heroin too. Now we're seeing a ton of fentanyl in the heroin, because this is manufactured on the street, basically. So we don't know what's in it. We know it's very unsafe, but we know all of these chemical compounds do bind to our opioid receptors and stimulate them, which do produce, anesthesia, management of pain. It also can be pleasure producing, which is why we see oftentimes it does build a dependence, because it increases opioids increase dopamine levels. So it's a pretty complex chemical interaction that we see. It also can suppress respirations, which is why it can cause overdose, and can be quite dangerous with other medications or in high doses that cause central nervous system depression. So yes, quite a broad range of different chemicals. So yeah.
Mm-hmm. So does OUD only affect middle class white people?
Yeah, I think that going back to kind of the title of this live and dispelling myths, I think that is a pretty common myth. I think that anyone, quite frankly, can experience an opioid use disorder. It just looks in different shapes and forms, but it could be anybody. It could be your neighbor. I think there are certainly trends that maybe if we did some extensive research currently, that we could find some trends in what substances affect what ethnicities, but altogether, I think addiction in general, but specifically today, opioid use disorders, I think that it's quite a myth to say that, only these kinds of people experience it and other people don't, because it could be anywhere. It's because humans are susceptible to kind of that developing some kind of unhealthy relationship with any substance or anything in their lives, and specifically if it's opioids. I mean, it's out there, whether it's in prescription form or illicit form like heroin. But I think that to me, I think that again, there's quite certainly trends, but I think that it doesn't only affect those people.
Okay, so y'all have heard it here on Heartland's Facebook page that this affects everyone. It's not just a young, old, white, black, it's everyone. So it's OUD an epidemic?
So yes, opioid use disorder is a disease, and it has disproportionately affected our society. So it remains at epidemic levels in the US and worldwide. Currently 3 million US citizens and 16 million individuals worldwide have had or currently suffer from opioid use disorder, and more than 500,000 in the US individuals in the United States are dependent on heroin. I was actually just looking at the statistics of this also. Most recently in 2019, according to the NIH in 2021 study, the number of overdose deaths have increased to nearly 50,000 as of 2019. From 2010 to 2017, overdose deaths related to opioid use rose from 21,000 to 47,000. So not only is it a disaster trend, but it's increasing almost exponentially. So very much an epidemic, sadly in the setting of a pandemic as now. But yeah, it's a real big issue. It's a buzzword we're hearing about, opioid addiction everywhere, and it's a real thing. We're seeing it every day.
So you bring up a very good point. So now that we've been in this whole pandemic for over a year, has it impacted that positively or negatively?
I think initially when what I noticed last year was initially everybody, when everyone was on lockdown, people couldn't go anywhere. So I did find that our patients were having an easier time managing their triggers and avoiding use because they weren't leaving and they weren't getting out and they weren't seeing people. And that's like, that was okay in the beginning. And then what we started to see was a lot of boredom, a lot of loneliness, a lot of isolation, a lot of lack of socialization, not getting anywhere. And, you know, after a certain point, you know, people outside of even just what we're talking about now were experiencing a difficult time not being able to go places like you normally would whenever you wanted and feeling safe doing it. So then we noticed a lot of relapses because a lot of people's triggers are from boredom and loneliness and not being able to go places. And so where going places was increasing the chances of being out of the house and using it was also eliminating that feeling of like being around people and feeling connected to the community and actually having something to do every single day, because it feels pretty awful when you wake up and you're just like, what am I going to do today? I can't go anywhere. And as we've known, as we've all learned, is like you can only spend so much time at home. So yeah, I mean, I don't know, Emily, if you had any other ideas about kind of the trends you saw with our patients, but I think initially it was like not that hard. And then now what we're experiencing still is kind of like these long-term domino effects of these lingering feelings of the isolation. And we're still in the pandemic, things are getting better, but people are still, I think this has had a really long lasting effect on people.
Okay.
Yeah, I agree. I saw the same thing. It was interesting because we talk about triggers being like people, places, and things, the 3 Ps. And when we were on lockdown, a lot of people whose triggers were people, places, and things, they weren't around those things. They weren't out on the street, you know, interacting with other individuals who probably weren't great influences, and they were using with them or, you know, being triggered by certain interactions. So in a sense, I think that isolation was helpful for some people, but yes, as also Michele said, boredom and isolation is a big trigger for people. So as time went on, people were isolating more and more and starting to, you know, have negative symptoms of that. And then the use definitely increased with a lot of people. So
Absolutely.
interesting.
So like this conversation comes up all the times, right? Is OUD a choice? Is it a disease? Is it like, what exactly is it?
So, yeah, I think unfortunately in our society, a lot of things are stigmatized, mental illness is stigmatized, but addiction even more so is stigmatized. Even in the mental health community, it can be sometimes. Whereas it might just be a character flaw. Like, why can't they just stop using? Why would you give up your social supports, your housing, your livelihood, your family, your financial stability? Why would you compromise all that to use these substances? Why can't you just quit? I have patients all the time say, do it for your kid. What's it going to take, you know? But the answer is like, no one wakes up and it says, I want to be addicted to heroin. You know, it is very much not a choice. It is a disease. And we do see with patients, once they're further on in their recovery, they may have a choice to say, I know once I go to the bar or I hang out in this situation, I know I'm going to use. So at that point, when they have that space, it might be a choice to not put themselves in a situation where it's right in front of them. Once people have it in front of them, often it's not a choice. And we get back into that disease model of where we do see measurable, observable changes through imaging with the brain. We see people's like limbic system become stronger, which is that kind of like lizard part of your brain that's very impulsive and very reactive to situations, and it's subconscious. You don't have control over it. And we see as people expose themselves more and more to substances and have less control of that prefrontal cortex, which is like the human part of your brain that has higher level thinking and takes control of what, like, you have that impulse, I want to eat 10 pizzas, you know, maybe that prefrontal cortex says like, not a good idea today.
Yeah.
You know, when that limbic system is so charged from these chronic substance use, you don't have that choice to say, I'm not going to use it. Someone could be staring you and say in the face and say, you will lose everything. And the other person would say, I don't have a choice. So, I mean, maybe initially up front, before you've used a substance, you might say, I have a choice to use it or not. But once your brain has seen it, once it's hit this, you know, ventral tegmental area and the nucleus accumbens and all these parts of your brain play into that limbic system. Once you have that hit from an opioid that gives you that massive hit of dopamine, your brain doesn't forget that. It doesn't go away, which kind of goes into that. Is there a cure? There's not a cure. You know, once your brain has seen that, once you have been kind of predisposed or familiarized with these substances, it's always going to be familiar. So we see people who get into recovery, they could be using for 10, 20 years. Once they've been in recovery for like a year to 3 years, we do see imaging changes where their brain tends to get a little bit back to normal, and they can behave normally and almost think normally, but it never completely goes away. Research shows that once you get that subsequent hit, you're right back to baseline. The brain is has a very primal part. I keep referring to the limbic system. It remembers pleasure and it remembers pain, because those are the two things that are most related to survival. And opioids are one of the most pleasurable things you can introduce your brain to, unfortunately, no matter how many risks they pose. So the minute the brain is re-exposed to that, or even re-exposed to a strong trigger that connects to that area, most people are really powerless to overcome that. So it's hard. It's sad to see people really struggle with it, because no one decides like, I just want to lose everything because of a substance.
Absolutely. No, absolutely.
Yeah, it's not a choice, really. It's a disease. It's the criteria for the disease model. We see brain changes. We see that it causes true harm to this individual.
Right.
It's diagnostic criteria for a disease. So
yeah, and then I mean, with the disease too, it's not just one approach works. We need to come from it from a medical standpoint, of behavioral health, the mental health, the spiritual. It's that biopsychosocial model. Using a really all-encompassing approach to it that you would see with other diseases, versus just like, okay, then just quit, right? Because if they could, they would. That's the whole point of it. Not if they could just not use and not think about it, they would. But I mean, going back to even the brain, we mentioned in the beginning, if we want to get, again, the technical part of it is like that dopamine, like, because after prolonged substance use, the thing that you're putting in your brain to create just inundated amounts of dopamine, and then you're not interested, and then your brain kind of goes, okay, well, like, we're putting something in our brain that's giving us that dopamine, that feel good, so like I'm just gonna like take a back seat, like I don't need to do it anymore. And so once they're not putting that substance in their body and having their brain get that back, the brain's like, oh no, I gotta come back from vacation. Like, it's really hard. That's kind of a really silly metaphor, but it's really difficult then. These people, when they're in like initially like in recovery, like they're excited about it, but then after a certain point it gets really difficult because their moods take a toll, and this is where we see a lot of the mental health part of things come out. And the other thing too is like, along with the cure, is like, this is just something that you're going to manage. Like, unfortunately, this could just be even with mental health or mental illness, you could manage it, you could cope with it, but there's always a chance for relapse with any kinds of these disorders. You could be in remission and then have a relapse of some sort, because by all means, like, the whole process is not linear. It's definitely a lot of ups and downs. It's a lot of maintaining and managing every day with all these different treatment modalities and approaches, but I don't think it ever fully erases and just vanishes.
So you mentioned that unfortunately there is no cure for OUD, but are there like medications or like treatments?
Yeah. So, and as Michele mentioned, it is very much like a biopsychosocial model. But we've found that if we use medications to kind of calm down that limbic system, that dopamine craving in our brain, that becomes so profoundly powerful that you cannot overcome it with any like rational thought or behavioral tool. So that's where medications come in and are really, really helpful to help calm that part of the brain, so you can start doing the work with the behavioral modifications, working with someone like Michele to teach you, how do I cope with intense emotions? How do I improve my interpersonal relationships so these situations aren't triggers? How do I cope with cravings? How do I find more positive outlets to stressful situations? Just like really revamping your relationship with that substance, your relationship with addiction, your relationship with maladaptive coping strategies. That's huge. I mean, you need to do that a real piece for long-term success and recovery. But some people can't even get to the space where they can do that work because that lizard part of their brain, that subconscious, is so on overdrive that all they think about is crave, 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 crave all the time.
Or their withdrawals are so severe that it's hard, it's going to be
Yes.
hard for them to engage on that level if really like we're looking at like medical kind of necessity of like helping them reach some kind of stability again medically before we can even address anything else.
Yeah, that's a really good point. So these medications aren't just used for like maintenance to help with cravings, they're used for withdrawal. So if you've known anyone or loved anyone who's trying to get off an opioid, it's disastrous. I mean, it's the worst flu you've
You're
ever.
very sick, yeah.
Very, very sick. So a lot of people, most of my patients who haven't been able to get into recovery successfully say like the withdrawals are too bad. Like I'm throwing up, I'm dehydrated, I'm on the floor, I'm profoundly depressed, I cannot handle this. So these medications give you that space to kind of, once you start getting into a moderate withdrawal, and I'll go into the medications real quick. You can take these medications and it helps your body cope with the withdrawal, and it also helps cope with subsequent cravings. And that's kind of how we dose the medications. So there's 3 medications that are FDA approved for opioid use disorder. One is methadone. That's probably the most commonly known one. It's been around for the longest. We don't prescribe that here. It's pretty tightly controlled and needs to be through certain methadone programs. One reason being is that methadone, this is going to get a little sciencey, is a full opioid agonist. It is an opioid like all other opioids. It stimulates your brain, and too much of it can cause an overdose and death.
Really?
So methadone is great for treatment of use disorder, but it needs to be monitored pretty closely because it can be dangerous if used inappropriately.
Which is why people have to go to a methadone clinic to get their dose.
That makes
Definitely
sense.
every day to start, but most days they go and receive their dose in the clinic and take it there. I just wanted to mention that because, you know, Suboxone's going to end up being differently. It's something that is prescribed to the pharmacy that patients take, you know, on their own every day. But yeah, just wanted to make that, because it's so tightly controlled and because of the nature of it, it is needed to be taken in the clinic.
Yes, exactly. So it has a lot of limitations in terms of, you know, people wanting to work a 9 to 5 or getting back to kind of their normal life. Like when you have to go to the methadone clinic every day, that can be a little taxing for people. I mean, it's a great for recovery because the alternative is much worse. But more recently, we've had a medication approved that was originally designed for pain management. It's also an opioid. It's not FDA approved in the US for pain management, ironically, but it is approved for opioid use disorder. So it's called brand name Suboxone, Subutex. There's a lot of them. I don't like to say just one because then I'm promoting the brand, but
Fair.
generic name is buprenorphine naltrexone, or naloxone. I'm sorry, buprenorphine naloxone is Suboxone. And it's also an opioid, but it's a long-acting, much safer opioid. It has what we call a ceiling effect. So if you accidentally take a little more than prescribed, it's not as high of a risk to cause an overdose. It stimulates your opioid receptor a little bit differently. It binds really strongly. It binds more strongly than these other opioids. So it stays in there, lasts for 24 hours, but it's also safer in that it's much less likely to cause an overdose on its own. In the setting of benzodiazepines or alcohol, of course, it's unsafe because it is an opioid, but it's safe enough that we're able to, once people are stabilized on it, to prescribe weekly medications, bi-weekly, or even up to monthly prescriptions. So people can kind of get back to a normal life. And then, so Suboxone is the one that we most commonly prescribe. Another one called naltrexone. It is not an opioid. It actually binds to the opioid receptor and blocks it. But we found that that type of connection can actually help with cravings. We found it to be helpful with cravings for alcohol, cravings for like carbohydrates, even. It's used in diet medications.
Really?
Yeah. So it is a great option for people who don't want to be dependent on an opioid, don't want to have to, worry about going through withdrawal. If it's a professional, like someone who flies a plane or operates heavy machinery and can't have the risk of being drowsy or on an opioid, it's a great option for those type of people because it can be a once a month injectable treatment that you continue monthly. And it's another really, really safe option that can be highly effective for people. So yeah, that's
Nice.
quick and dirty of the medications we use for MAT.
Nice. Can you explain the harm reduction model and how Heartland MAT's program is doing to actually follow that model?
Yeah, I think that, that was one of the very first things that we established when we started is, there are quite certainly abstinence-based models. There's absolutely nothing wrong with abstinence if that's the patient's goal. But what we do know is abstinence can be really difficult. It can be unattainable in the very beginning for patients. It can be unrealistic to expect people to just go from using something for years and years and then just absolutely never using it again for the rest of their lives. That can be really difficult. So we've kind of adopted more of a harm reduction model, which doesn't say like never strive for abstinence. It kind of just looks at what is your goal? Like, what do you want to do? Really like not just having a relationship with the patient and being able to say like, what's doable for you? What can we help you work on? Harm reduction at the basis is any positive change. So sometimes it's not always immediately making any changes and decreases in the use. Maybe it's, trying to figure out other positive ways that the patient can engage in change or just take better care of themselves. Maybe they're still using, but they're coming to their appointments, they're engaging in their care, they're doing meetings, or they're taking their medication anyway. And so we are not punitive when it comes to people ongoing use. The harm reduction just wants to express that empathy that like there's nothing wrong. We're not judging you. We just want to know what's going on so we can take care of you, so we can be there for you, and we can just make sure you're safe. There's just, we've talked a lot about, having a lot of risks with using, and we never know what's on the street now. And so things like naloxone, Narcan are some of the biggest harm reduction things, because this can help people were they to keep using, it's an overdose reversal drug. And so having their family members or their loved ones have it for them, something that can connect back to one of our later questions about how they can help support somebody struggling. But it's ultimately just like, how can we meet in the middle and figure out like, where do our goals overlap? Like, we want our patients to experience higher quality of life, to take better care of themselves, and to experience any positive change. And how can we meet in the middle with that, in terms of prescribing medication, encouraging that compliance every day, encouraging them to engage in their recovery, but also them also naming that goal for them and having that motivation from themselves to also want to be healthier.
Got it. So can you explain the MAT program in Heartland?
Sure. So you've already kind of introduced us. We're probably like the core team, you might say. Jeannie, you're part of it too.
Yes, we are.
So yeah. So basically, as I said, it's kind of evolved to the MOUD, medication for opioid use disorder. So we use those interchangeably. If people have heard MOUD, I guess that's the more modern term. But yes, so we, as Michele said, very much harm reduction, meet people where they are at. Evidence supports, any positive change is often, a really effective way to meet people who are maybe not ready for full sobriety, but we can keep them safer than the alternative. We know that people who are engaged in a program like this, even if they're not fully sober, are 70% less likely to overdose and die. So we just try to meet people where they're at. That being, we'll get more into like who's eligible, but we bring people in. We are strictly outpatient. We can follow up with people as much as twice a week. And once people get a little bit more stable, we go, weekly, every 2 weeks, 3 weeks, up to a month. As Michele had mentioned earlier, recovery isn't linear. Oftentimes people face certain struggles or triggers or lapses, and that's okay. That's part of recovery. We know this is part of recovery.
Mm-hmm.
So if people have something that's kind of destabilizing or they end up using again, we'll bring them back closer, follow up more frequently, provide that support. But basically, I'm the one that prescribes the medication, so they'll see me for that. I do some primary care too, make sure it's a safe fit. Suboxone is, buprenorphine is very, very safe, but a few things we want to make sure, their liver function is healthy enough for it. that they're not using excessive amounts of other central nervous system depressants. So we talk about safety, and if there is continued use, which we do see with some patients, we're doing a lot of education around harm reduction with Narcan, or even just radical harm reduction, like using clean needles or nasally versus IV, or using with others. So if one should overdose, someone else is there to save them, and that there's Narcan on hand. So we talk about, various levels of harm reduction and just really meeting people where they're at, giving them medication, following up with me for that. They're on the phone with Rihanna, like all day, every day. She has a number that goes straight to her. So like, she's everyone's best buddy. She knows all their inner secrets, but they call her and she connects with whoever. And then, they'll follow up with Michele too, and do that work as we talked about on the behavioral health and coping with cravings, working on, distress tolerance or different ways to manage their recovery, talking about use, talking about barriers, talking about connections to resources. If they need a higher level of care, we have partners with like Gateway Foundation and Thresholds where we can refer them an IOP or an inpatient program if that's required, because we really are that lowest threshold of care. Someone needs more support that we can't provide at this outpatient level. Michele's great at making those connections too. So yeah, overall, I think we're a good, comprehensive, supportive team. We're within a primary care setting. So if we need to link people with psychiatry, we can connect with that. We have a lot of resources here, which is pretty great. So.
No, that does sound great.
Yeah.
So who's eligible for the MAT program in Harlan? And I feel like we can answer this all together and say everyone, because we literally accept anyone and everyone to this particular program. You don't even have to be a citizen. You don't have to have insurance. You could be an immigrant. You could be a refugee. If you need the assistance, we are here to help.
Yep. Yeah. I mean, truly, we had a patient recently who was living in Miami, Florida, did not have insurance, didn't know where to go, with calling around, just failing. Had some friends that lived up here, moved up to the city and came to us for treatment uninsured. We had a rough induction because he was only using fentanyl, but we got through, and he's sober still. And we transferred him back down to Florida. We helped him find
we were able to continue until I knew, until we dropped him off fully to the front door of the other, of where he's at now. And even he had appointments, but he was like, I just want to make sure I'm comfortable and everything. Cause it was hard. We worked with him for a while, and at the end, he was just so grateful. And it's a little bittersweet, cause it's I like, working, we'll miss them too. And so it's hard kind of for both parties.
Yeah, they become like family.
Absolutely, I'm sure.
How do we bridge that gap?
Yeah, sorry, I mean, early on when we first started, we did, because we didn't have as many prescribers as we do now, it was very much, of course, only for Heartland Health Center patients because of our model, our patient-centered medical home model. But now with our increasing of prescribers, we've been able to expand the access and just not have more barriers to treatment than there already are, than there already exists. So being able to have the capacity and expand, not setting up a bunch of roadblocks for it, just making it as easy as possible to start.
And to give a little bit more information on how amazing the resources are, we have grant funding that covers medications. So this guy we've referred to, he did not have a job. He did not have insurance. We covered his visits and we covered his medication. So he was super grateful to have those resources. That we have plenty of patients come to us from private insurance or private providers, and they're paying, $300 out of pocket for a visit and $150 every 2 weeks for Suboxone. So it's crazy, what people are paying, and amazing that we have the resources to kind of subsidize those costs.
Again, kind of overcoming some of those barriers, and being able to provide this treatment that it's definitely really tough. So we have the privilege to be able to do this for people who really wouldn't be able to obtain that treatment, and then who knows kind of where they would be in terms of their recovery or their quality of life. And the fact that we can help support people to get back to that point that they are able to kind of get back into feeling more functioning and have a higher sense of self-efficacy, and just feeling like they can start to get back to what normal life is going to look like, kind of get back into their goals.
Nice. So what are you doing to help patients in recovery stay on that path?
Whose turn is
Support.
it? I'll jump in. So,
Go.
I mean,
Yes.
we obviously, you know, our regular appointments, and then we always try to have our patients have regular check-ins with Michele, to just continue to talk about triggers and managing those. And then we also have a peer, his name is Joe, and so we encourage our patients to really kind of almost just like develop a friendship with him. He's also in recovery, so he has a lot of insight and, you know, can talk to the patients on a different level of what they're going through and how to manage and
Lived experience.
yes, he has lived experience, so that it just is a big comfort for a lot of our patients having him to talk to. And
he brings a completely different level of empathy to working with this patient population. It can be really common for this population to say like to feel like nobody understands what they're going through, and that, well, you know, we must not know how hard it is because we haven't been through it. And that's where, you know, Joe can come in and establish that rapport on a different level and help work with patients on that and kind of getting them motivated, help them, you know, understand what we do, but not hear it from us because they might not even be open to hearing it from us. It coming from someone like Joe might be a lot easier for them to understand. Yeah, we mentioned linking to resources that are outside of Heartland that we don't provide, and still following up with them. We refer patients for intensive outpatient programs, which are groups that meet a few times a week, like through Gateway Foundation or Illinois Masonic. And this is just a higher level of care because some people really do need that specific time, about 3 days a week for a couple hours, to really talk with other people in recovery and have that more educational model to it, a much structured model to recovery, and being able to participate in that. And then we'll still follow up with them for the medication, for the behavioral health check-ins, for the peer check-ins and things like that. So just making sure that they are well supported and that we're constantly assessing what is their goal and what are they willing to do, and then what do we recommend, and again, trying to constantly find that middle ground because that could look different every single week.
Absolutely. And so I like to kind of pause the conversation here to kind of play up Joe. Unfortunately, Joe could not make this conversation with us, but y'all, he is amazing and he really is a good source of support. He's personally just like very encouraging. He's very like just nice and warm and welcoming. So Joe is amazing. Yes, very easy to talk to. Very, very easy to talk to. Okay. So how can a loved one or a friend support someone with OUD?
Do you want me to take this one? So kind of just circle back to what we spoke about with like, is it a choice? I think having that just really central in your interactions and communications with a loved one, like understand that this is a disease like any other disease. I'll often say to frustrated family members, like, what if your family member had like a leg amputation because, you know, they had a deformity or whatever? Would you yell at them for not being able to run, you know? Or what if someone had cancer? Would you speak to them this way? Just really cultivating some empathy with those loved ones, while also validating their stress and their fear and probably their trauma around it. Like a lot of loved ones who walk alongside people who have experienced opioid use disorder are traumatized. They've watched doses, they've watched them do well and then lose it all. You know, it can be really, really tough for family members. But just recognizing like the perspective of it is a disease, it isn't linear, the recovery, you know, people can get better and then, you know, 3 steps forward, 2 steps back kind of thing. But just like even the harm reduction, meeting that person where they're at, like, I'm here for you, how can I help you right now?
Right.
So
and also too,
go ahead,
sorry, go ahead.
No,
it's also knowing too, like we talked about, you know, again, recovery is not perfect, recovery is not linear. And I know that it can be really hard for loved ones and family members to be so happy when the patient's experiencing so much success and then start to see maybe a decline again or a relapse. And I think that there's a tendency for those loved ones to feel like it's something they did, or they could have prevented it, or they can save them, and knowing too that there's a boundary there, that like they're not ultimately responsible for that relapse or whatever it is. And so, you know, a lot of it too is like Emily mentioned, the understanding, it's being educated about it, it's you know, being supportive, it's being encouraging, because and sometimes it just takes that motivation from somebody else, but also not being shaming, you know, because this population is already putting so much guilt and shame on themselves. So we would not want, you know, family members or loved ones to add that shame, but also encouraging family members and loved ones of this population to seek their own support where it's needed, seeking their own counseling, seeking their own therapy. There's Al-Anon or Nar-Anon. So these are specific groups that are for family members or friends or loved ones of people with a use disorder of some sort, and people can get that support from that group. So, you know, kind of noticing where they might need to seek their own support.
Yeah, and in line with that, I think boundaries are like it's a really helpful concept for going through something like this. You know, loved ones have to have boundaries with themselves. Like self-care is key. I mean, if you're or to love a family member who's really struggling, you have to make sure that you are caring for yourself and performing self-care and having those boundaries of like, I can give you 3 days a week to be here for you, or I can give you shelter with contingencies. I can give you this, but at the end of the day, I still need to take care of myself, and having that balance and those boundaries to say, I'm here for you. I love you. I'm not going anywhere, but I'm also not going to enable this behavior. And that depends on the person and on the family and the relationship. And those are fluid situations, and those evolve, and it really depends on the case. But just having very clear expectations and communication, and just upfront making sure everyone's needs are met is really important.
Absolutely. So this next question is
one more thing.
Yeah, go ahead.
Yeah, I was going to say, thank you. Is like another way to support someone with opioid use disorder is like very realistically, it can be lethal. So knowing like harm reduction, knowing what the signs of, you know, worsening symptoms are, knowing how to administer Narcan if you that your loved one has experienced overdose, doing that education. We'll bring family members into the clinic and do education with them of how to administer it. It can be injectable or an intranasal spray. Making sure that you have that on hand as a family member who loves somebody or a friend, you know, or a colleague, whatever, knowing someone in your life is using opioids, having the education and the access to that reversal drug so you can save a life if it comes to that.
Oh yeah, that's a very good point. So the reason why I really wanted to have this conversation, right, is about barriers, it's about stigmas. So one, is there a shame or guilt around OUD? If so, why? And the third part of that question is like, what can we do to actually break down these barriers and these stigmas?
Yeah, I feel like it's kind of what we've discussed so far is just I think there's a stigma around addiction period. So opioid use disorder, yes, there's a stigma we've mentioned around mental health in general. It's difficult because it's not as normalized as, say, cancer, right? We would never say like, why can't you just get over it? Or like, are you, or even, you know, something like diabetes, you know, in the beginning, we don't, you know, we know that like there are oftentimes people struggling with that medical condition who are not always making the best food choices, but it's still something for them to, you know, it's something that they have to manage every single day, and they might need medication, they might need counseling and education. So we kind of try to apply that same concept. So trying to break down the barriers, trying to break down the stigma by normalizing it like that as another kind of medical condition, and not, you know, not using terms sometimes like clean or dirty in terms of like urine screens or anything like that, and just not associating use disorder with some kind of failure or moral failing or like you're a bad person. So not associating those because people really, again, will take on that guilt and shame. They already feel really guilty about the way that their lives have become kind of out of control, the way that they've hurt their family and their loved ones, the way that they are just not on the track of their life that they expected or imagined. So whatever it is, they're already putting so much guilt and shame. And typically, you know, that's causing a lot of it's causing a lot of sometimes even just depression or anxiety for them. And so again, I think the more that we have people in positions like this, like in a healthcare system or a healthcare center, who can use the best language possible and can be as open as possible, non-judgmental, being able to be aware of the services that we provide, and in a non-judgmental way, in a harm reduction way, and not having an open mind. I think, not being uncomfortable with these kinds of conversations. I think that's the start. That's where we can start to try to, reconcile some of the I was losing my train of thought just then, just reconcile some of the stigmas and just the myths about it, like as we've mentioned.
Got it.
And even to like go piggyback on the terminology that we're kind of changing. Michele said we don't use clean and dirty anymore. We say like their urine drug screen was positive or negative for this. It wasn't clean or dirty because that carries certain connotations. Or we don't use the term like addict anymore or abuse. It's not substance abuse, it's substance use disorder. Mm-hmm. A colleague sent me a screenshot the other day that a patient had gotten as a discharge instruction and said, stop abusing cocaine. And we were like,
no way.
I won't say what organization it was from, but not ours. So they're right. Still very much out there that this you're an addict, it's abuse, and it just carries such a negative connotation that perpetuates this stigma. And yeah, you want to talk about like just talking about it?
I was just going to say, I think a big part of just breaking down that barrier is to start talking about it and to have an open conversation. Feel like somebody, a friend or a family or something, maybe is having some issues, like have the conversation. It can be awkward at first, but and
I think unfortunately
want to talk about it.
Right. I think unfortunately there's, of course, we want to be culturally sensitive. There's a lot of cultures that just don't it's not a common thing to discuss, addiction or mental health, and we want to be sensitive to that, and we want to be understanding of that, but we also we want people to know like we are a safe place for to have that conversation the first time maybe they've ever had it. Their family might not know, people might not know, but like we're a safe space to start to have that first conversations, to kind of allow people the space and the validation to like admit what's going on and to be open about it, because they probably just can't be open with anybody else. And like Rihanna said, it's going to be uncomfortable, it's going to be awkward, but we never know if that's going to make a difference. We never know if that's going to kind of help incentivize someone's thought process of like, maybe then they might still be ambivalent, like I don't know, but like at least somebody that cares about them has mentioned it to them, and then it'll be in the back of their mind.
Absolutely. So can people with OUD be convinced to actually like seek treatment?
It's so funny that I literally just said like, oh, like they might think about it for a long time. Ultimately motivation is really complex. I mean, think about how like I would love to work out every single day, but do I have the motivation to do it? I want to, but and so motivation and actual willingness are two different things. Actually being ready to do something, and then also the maintenance of something is really hard. As we know, sometimes getting started with something is okay, but like, oh my gosh, now I have to maintain it every single day, I have to do this every single day. That's hard work. And so I think, again, motivation changes day to day. This is an understanding that people who work with people with use disorders just inherently know, is like our patients might be really engaged sometimes and then have, struggle to engage other times. And so I don't think you can ever force anyone to do anything that they're not willing or ready to do themselves. That kind of goes back to family members and loved ones supporting people with these disorders. It's like you can want something for someone, but you ultimately can't force them to do it and engage. So I think we can motivate people, we can encourage people, we can provide options and opportunities, but I don't know that convince people. I think we can be strongly encouraging, but yeah.
Fair. Okay, so Amanda, we are going to take some questions from the audience. So yeah.
And I'll be on for just a few more minutes before I hop back on to
perfect
sections.
Okay, so let me just pull them up, bear with me. So what are the signs and symptoms of worsening OUD to look out for as a loved one?
Should I take this one?
Yeah.
I mean, it really depends. It's such a case by case basis. But a lot of times we'll see different stabilizing factors start to take a hit. Like people tend to isolate when they're getting worse. So social connections might be the first to go. Engagement in certain, maybe groups or outings or plans, or if someone is, maybe in a recovery group or anything, it's just basically that social engagement starts to suffer. People tend to experience shame with worsening use disorder. So they tend to kind of isolate more and more. A lot of times, if people are using substances heavily, we'll see some financial stressors because it does get quite expensive. So people might start asking for money. People might have financial challenges that weren't present before. People might not start showing up to work. People might start really abandoning their self-care practices, not showering, starting to lose weight, exhibiting signs of like dehydration and malnutrition, and just, mood symptoms. Sometimes we might see people be more emotional, more irritable, maybe just a lack of mood, kind of just a flat affect, just really withdrawn. So all of those things we'll see. And then if someone's actively using, if you see someone in withdrawal, you might see them, start sweating, start getting anxious, kind of like sniffling, runny nose, things like that. We'll see, but yeah, I don't know. Michelle, is there anything you want to add?
Yeah, and that'll be kind of my exit out. I do agree with
Yeah.
you. I mean, if you know someone well, you'll start to notice differences, and we don't want people to like pinpoint or microscope every single thing, because I think our population is sensitive to that. But I do, there are going to be some noticeable changes in behaviors or mood. And again, I was going to say my first thought was the isolation. So like you notice that they're more closed off. In people have good intuition. You can kind of sense like something's kind of off, and maybe it's not even like a pre-relapse or a relapse itself. Maybe it's something else that's going on, but addressing that thing or getting support with that thing can probably help prevent them from building on that trigger, and that might eventually lead to a lapse. But first, anytime that you feel that you're like losing a connection and you just don't feel connected with that person, something's probably going on. But I do have to run. It has been an honor and a pleasure to be a part of this. Thank you guys so much.
Thank you so much, Michelle.
Bye. Bye.
So we're just going to continue the conversation with Michelle, because this is a really, really good conversation, but we're almost done. We're just wrapping up now. We kind of answered this question a bit earlier, but does it cost anyone to receive services at Heartland Health Centers?
So it kind of depends. If you have insurance, there could be a copay associated with your visits. And then, there's a lot of, I think all Medicaid programs cover the medication completely. So there's visits. And the visits. Mm-hmm. But if you do have like a private insurance, you might have a copay, like if you have a general copay when you go to the doctor, as well as there might be a charge for the prescription, but most often it is completely covered.
Got it.
And for uninsured, it's on a sliding scale. So the amount of financial funding we have to subsidize those costs is kind of variable depending on where we're at with that. But say we had no financial backing and it was just kind of sliding scale and pricing that we get subsidized from the government for our medications. So sliding scale, the lowest sliding scale would be like $25 or $30 a visit. Mm-hmm. And then the medication, the Suboxone, we have a program called 340B program, mm-hmm. where we get reduced pricing on certain medications due to our kind of the status of our patients. So a month's worth of medication, if you're taking it twice a day, is $34. So it's pretty reasonable compared to what a lot of other locations.
Absolutely, sounds like it. Okay, so how can I get naloxone if a relative is using substance and they're not willing to seek help yet?
So we have it here.
Yeah.
And we can, You can call, this is a good question because it keeps evolving how it's accessible. So you can get a prescription for it and that's covered. So your own prescriber can prescribe you naloxone and the pharmacy has to dispense it at no cost, or it's covered by insurance. So that's the intranasal one, which we don't give out regularly because it's really expensive. I want to say it's like $300 per little container, but it's covered by insurance and anyone can get a prescription for it. So that's a good thing you can pick up from the pharmacy if you want that yourself for a loved one, or if you can call our clinic. We do give out Narcan here free of cost. Also the
Narcan nasal spray is available in most major pharmacies without a prescription. This includes CVS, Walgreens, and Rite Aids. In most cases, Narcan's cost is covered by insurance.
Yeah, so it's a little, I guess it is accessible without a prescription. It can be a little expensive, but yes, the injectable Narcan we give out for free here. We can do trainings, teachings on it. Also Thresholds gives it out for free. Chicago Recovery Alliance, you can look up CRA. They are an amazing resource. They're super like grassroots on the ground. They are in the community. They do clean needle exchanges. They do free Narcan training, naloxone, Narcan, same thing. They give those out pretty readily. It's easy to get from them for sure. So just pretty much any federally funded program that provides MAT gives free Narcan usually.
Okay.
Yeah, give us a call. We can get you some.
Yes, we can. So how would I know if someone overdosed if they have OUD?
So basically, opioids in excessive doses cause respiratory suppression. It basically stops you from breathing. It will kill you because of that. So when your brain and heart are starved of oxygen, they stop working and you die. So basically it suppresses your respiratory drive. Interestingly, we give opioids sometimes in hospice care with people who have end of life, like severe respiratory illnesses, to help decrease that respiratory drive so they can kind of be comfortable, I guess. But excessive amounts do stop breathing. And that's how people overdose. So if you find someone who is not breathing and unconscious, give them Narcan right away, call 911.
The thing?
Oh, we call this. Anna loves this. It's called a sternal rub. Basically, you take your knuckles right on someone's sternum, rub it real hard. That's we call it a noxious stimulant. It's really painful. That doesn't wake someone up. A good chance that they're not conscious. So don't ever give Narcan to someone who is conscious and speaking to you. You will put them into an acute withdrawal and they will hate you. And they might be very violent. That said, people who are unconscious and overdosing can wake up and react pretty unpredictably, I guess I'd say. So when you do give Narcan, this is not a formal training, but when you do give it, it will pull people out of an overdose and they will wake up right away and be in an acute withdrawal. So it is life-saving, but you want to call 911 right away. If you find someone, give it, call 911, stand by. It can be administered again if it doesn't fully bring someone out, but I'm not going to get into the details of that. But yes, it can be administered if someone is not breathing and found down.
I was going to add, it's also very important that you do call for help after administering it, because I do know that like fentanyl especially it stays in your body much longer. And so I believe they say Narcan only lasts for like 30 minutes. So the Narcan can wear off and then the patient go back into.
Really? Oh, that's very interesting.
Yeah. So it is, you don't just like give them Narcan and let them wake up and call it a day.
Right.
You call 911.
And people do get nervous, like, am I going to be implicated? Am I going to be arrested? Oh my gosh, if I'm using with this person, I don't want to. We've lost a lot of patients to the other person not acting because they were afraid of the legal implications. Right. No, our fire department, our EMTs, our police officers are trained. Like if you call, they will support you. They will help you. They will not arrest you. So call 911 if you see someone down, whether you're a part of it or not. You can call 911 and tell them where the person is and you can run if that's what you need to do. But always call, always report it.
Nice. Do you offer your services in other languages?
We do. It can be challenging sometimes, but we do have interpretation. So we definitely just kind of allow for more time during those visits. Just, you know, because it's obviously easier if we can just have a conversation. But we have interpretation services. So if you're in clinic or doing a phone visit, anything like that, we can include them. And yes.
Yeah, we currently have a patient who only speaks Spanish, and we have met with him weekly. We give him an hour-long visit. We use the video interpreter so he can see the person we're speaking to, and I sit right next to him, and it works pretty well. Yeah, we allow more time because of obviously everything has to be said twice.
Right.
And we want to make sure there's clarification, but yeah, definitely we have interpretation services for like, oh my goodness, tons
All of the languages.
all the languages. So yes, language should not be a barrier to care.
Absolutely. Okay, good point. So are we currently accepting new patients right now?
Of course we are.
Yeah.
Always.
Rihanna, you can talk to the lovely Rihanna if you call our
Yeah.
number, which is the number. Go.
312. So if you call our number 312-590-2291, it comes directly to me. So it's super easy. You don't have to go through the call center and you know, do anything like that. It comes directly to me. I can register you as a patient. I can get you scheduled. We always try to do, we always aim for at least same week appointment if possible. Obviously if you call on a Friday, we can't do that, but it's super, super easy.
Fair enough. So are these appointments in person? Are they telehealth? Are they both? What?
Right now it's kind of both, because, you know, COVID is still an issue. We are definitely working more to being in person, but it's kind of like a hybrid of both right now.
Okay.
But
Well,
it's
thank you.
great.
Oh, go ahead.
It's been a great like a reduction in barriers for individuals who live far away and have limited resources for transportation. It's been really amazing in helping us expand our reach. The telemedicine's been great. So we've been doing a lot of it. Now that we are having people in person, generally with our, you know, most stable people, we have them come see us once a month in clinic. Because I am required to document that they're taking the medication, do occasional urine drug screens just to document again that they're taking the medication because it's a DEA requirement. But yeah, for the most part, we can do a hybrid and people really like it. It gives them more flexibility. They can do a call when they're at work with us over a break. It's pretty cool. So yes, you will come in person to get some baseline labs. We want to make sure you're healthy enough for the medication. But we can be super accommodating. Minimum monthly follow-up, but yeah.
Well, thank you, ladies, for this amazing conversation. I want to, in spirit, thank Michele. I'm also going to be reaching out to her privately to thank her personally. But unfortunately, we have gone over our time. But you guys did an amazing job. This was an awesome conversation. So for my Facebook family out there, if you don't have a medical home, I'd like you to call 773-751-7800 to become a part of the Heartland family. If you have OUD, or if you know someone that does, and who is ready to start treatment, remember we are here for you, and it is an outpatient treatment program. And Rihanna, tell them the phone number of where they can call.
Yes, it is 312-590-2291.
Thank you. We look forward to serving you. And as always, if you have any questions, comments, or concern, please feel free to reach out to me. Once again, my name is Gina Smith, and I am the Community Outreach Coordinator here at Heartland Health Centers, and it is an honor to serve you. Bye, everyone.
Bye.
Thank you.